Awesome. We'll do that. Okay, can everyone see this?
Yep.
Okay, great. So I will be presenting today on the article applying an equity lens to characterizing the processes and reasons for an adaptation to an evidence-based practice, or EBP, as I'll be referring to it during this presentation. So this was written by, I don't know how to pronounce the last name, but Sjoberg et al. And during this presentation, I just encourage you to interrupt me, primarily because I can't see the chat. And just ask any questions that come up. And if you want to, you can also use the chat and we'll address questions.
And I'll watch the chat for you too, Heidi, and any clarifying questions I will interrupt you for.
Awesome. Good. Thank you.
Yep.
Cool. So here are just some questions that I thought about that I wanted to get you all thinking about this article and how it relates to, to your research. And I'll post them again at the end of the presentation as well for us to talk about. So EBPs are often adapted in various settings to fit their context and culture. And this article highlighted that adaptations can be made to address inequities, which I'll discuss more later. While adapting EBPs, there needs to be a balance with fidelity, since adaptations can impact the effectiveness of an EBP. Adaptations can either be fidelity consistent or fidelity inconsistent with the EBP's core components, and they can ultimately impact patient outcomes. So fidelity consistent adaptations do not adjust the core components of an EBP, whereas fidelity inconsistent adaptations do actually alter the core components. There's not a lot of research out there on the pros and cons of fidelity consistent versus inconsistent adaptations. However, this article notes that ensuring fidelity to the core components is not always in the best interests of the intervention in terms of patient outcomes, especially while you're considering inequities. So at times, fidelity inconsistent adaptations need to be made. Why adaptations are made by providers is often not examined or well understood, which is something the study wanted to understand better. So this article examined adaptations made in a previously implemented EBP called InShape. InShape was an intervention to address obesity and promote weight loss for people with serious mental illness. People with serious mental illness who experience comorbidities are one of the least recognized health disparity groups. Health disparities are often associated with economic, social, and/or environmental disadvantages. And so InShape targeted this population as their participants. And so it consisted of 3 core components. And so the first one was weekly individual meetings with a health mentor or fitness trainer who provided instruction and motivational support, and also helped develop individualized exercise and health eating programs for each of the participants. The second core component was securing free or low-cost community gym or fitness facility memberships for the participant and holding the health mentor sessions at this community facility. And then the third core component was group motivational celebrations. So InShape aimed to reduce cardiovascular risk through weight loss and improved cardiorespiratory fitness. And adaptations through the implementation of InShape were tracked by the providers, and they were later evaluated to understand the impact of the adaptations. InShape was a hybrid type 3 implementation study that evaluated the effectiveness of a virtual learning collaborative compared with technical assistance throughout the implementation of InShape. And they didn't go into the details about this since that was already reported in an earlier paper. But just to quickly, give a brief summary of it, they used a cluster randomized controlled trial, and they had 55 mental health provider organizations that were randomized to the implementation of InShape, and 39 of these sites were assessed at the 24-month follow-up period. And all of these sites were invited to participate in an additional 1-hour semi-structured interview by phone to identify adaptations made to InShape. And of these sites, 37 of them participated in the follow-up interview. The interview was audio recorded and transcribed for data analysis, and the adaptations were determined to be either fidelity consistent or fidelity inconsistent. They evaluated the impact of the adaptations on the implementation and patient-level outcomes. And they found that 5 of the 37 sites had a fidelity inconsistent adaptation. And so those are the 5 sites that were the main focus for this article. And so the authors of this article wanted to dive deeper into the successful fidelity inconsistent adaptation that was made while implementing InShape. So the aim of the study was to characterize the process and reasons for the fidelity inconsistent adaptation to InShape at 5 of the sites who implemented it, with a focus on the role of social determinants of health and inequities in the specific adaptation that was made. If you recall the core components of InShape that I mentioned earlier, The adaptation made by the 5 sites was specific to core component number 2, which was securing free or low-cost community gym or fitness facility memberships for the participants and also holding the health mentor sessions at this community facility. The adaptation that was made was moving the health mentor sessions from the community gym or fitness facility to the local mental health center. They examined the extent to which the modification was fidelity consistent, and they determined that it was fidelity inconsistent since it changed a key element to the core component number 2 by not implementing the health mentor sessions in the community. For this study, 2 of the authors, who were implementation scientists, reviewed interview transcripts from the 5 sites that were identified to have the fidelity inconsistent adaptation to InShape. They independently read and coded the transcripts to better understand the adaptation, and they did qualitative coding and informed by template coding, and they met after coding each transcript to review the codes and discuss discrepancies until consensus was reached. So while reviewing the transcripts from the interviews at these 5 sites, the authors used a template that outlined the domains of the expanded framework for reporting adaptations and modifications, or the frame, which I think a lot of you are probably familiar with. And they use this as a guide to apply constructs that represented the process and reasons for the fidelity and consistent adaptation. So while they were examining the reasons for the adaptation, they utilized an equity lens and assessed whether social determinants of health, including poverty and discrimination based on having a mental illness, interacted with the socio-political environment, the organization, provider, and or participant to create obstacles to access and use of the community-based facilities and gyms, and if that was a reason for the fidelity inconsistent adaptation. And so you look at this table where they kind of mapped out the adaptations that were made. And so you can see the frame categories, including an additional one on social determinants of health, are the columns, and then the answers from each site are listed in each row. So they evaluated and reported 8 aspects of the adaptations to InShape. So the first one, they looked at whether it was planned, so intentionally occurring in advance of the implementation by design, or if it was unplanned and reactive. So that means like if it occurred during or after the implementation without advanced planning. Which you can see here, the adaptation was primarily unplanned and in response to challenges that occurred while implementing InShape. There was one site where it was unclear, but the other 4 sites, it was an unplanned adaptation. So they also looked at who determined that the modification should be made, which in this case was always the intervention team. And then they looked at what was modified, which across the 5 sites was always the content and the context. They looked at what level of delivery the modification was made, which was always to the intervention group. They looked at the contextual adaptations that were made, which was the format and setting of InShape. And they looked at the nature of the content level modification, which they all either like tailored, removed, skipped elements, and they also substituted or added elements to the implementation. And then they looked at the reasons and the goals of the modification. So was a reason to improve fit or adapt to a certain culture. And they also looked at the contextual factors that influence the decision directly and indirectly. So in this study, the adaptation was to improve the access, feasibility, and fit for the participant needs, and to increase the reach and decrease the cost for the participants. And then lastly, they looked at how social determinants of health affected the participants' access to and use of the community fitness or gym facilities, and how they played a role in the fidelity and consistent adaptation. So taking a closer look at these social determinant of health results that they found that lack of reliable transportation, cost, and mental health stigma were key barriers to accessing and using the health mentor sessions that were held at the community fitness facilities or gyms. And this caused the organizations to adapt the program by offering the sessions locally at the mental health center. So transportation was a huge barrier because it wasn't readily available or easily accessible in the community for the participants. The participants were also hesitant to use public transportation. They experienced long travel times, making it undesirable to attend the sessions. And then there was one site that I think the health mentor was driving the participants to and from the sessions. And there was substantial drive time involved, which was difficult for the health mentor to keep up with this just with driving everybody everywhere. And so many participants also lived in group homes or sites, and they were worried about traveling on their own. Cost was also an issue. So participants felt that gym memberships didn't align with their preferences. So they may not have wanted to spend money to go there. And they also didn't like the atmosphere of the gyms. Cost of transportation was also an issue since it was only reimbursed by insurance when participants went to a mental health facility, but not to a gym. So having the health session, the health mentor sessions at the mental health facility improved attendance because the participants could use a taxi that was reliable and also reimbursable for them. And then the others also identified that the fitness facilities actively discouraged clients from obtaining memberships, and they wouldn't work with the implementation team to provide a good environment for the clients to be in. And then lastly, they found that mental health stigma was a huge issue. So the gym staff were worried about clients using the gym unsupervised or having disruptive behaviors due to their mental health problems. And they were also worried that participants would use the gym all the time. They only wanted them to go there with a health mentor. So that was a huge barrier as well. So to summarize the results in this study, they evaluated the process and reasons of fidelity and consistent adaptation at 5 sites who implemented in SHAPE. And they found that social determinants of health were the reason for this adaptation. The unplanned adaptation was changing the location of the health mentor sessions from a community-based gym or fitness facility to a local mental health center. And the intent of the adaptation was to improve access to services, feasibility, and fit of InShape to the participants. And they found that all those social determinants of health that I discussed on the last slide were the barriers for the participants in accessing fitness facilities or gyms in the community, which led the InShape intervention teams to adapt InShape to address these barriers. And overall, this fidelity and consistent adaptation led to a result from their earlier study of InShape that reduced the risk of cardiovascular issues. And so they had some limitations. They had a small sample size of 5 sites. It was also a retrospective nature of the adaptation interviews. And in the study, it was also a secondary use of the qualitative interview transcripts to investigate the reasons for the fidelity and consistent adaptation. During the original study, they also asked teams to recall adaptations 2 years after the initial training and implementation. So there could have been some recall bias. They might not have, remembered specific details about the process and the reasons for the adaptation that they made. And also during the initial interviews, they did not specifically ask the teams to describe the modifications made to the intervention to address inequities, which if they had, it could have revealed additional adaptations that were made to promote equitable implementation. So some key takeaways are InShape had a fidelity and consistent adaptation that addressed social determinants of health at 5 sites that improved patient outcomes. And there's a need to consider whether fidelity and consistent adaptations to EVPs may reduce inequities in access to and use of care for health disparity groups. And using a health equity lens and considering social determinants of health to develop and adapt EVPs may be vital in addressing obstacles to access and could also improve patient outcomes. Also, understanding stakeholders' decision-making process pertaining to adaptations helps understand how and why adaptations were made, and that could ultimately promote scale-up and sustainability efforts for the EVP. And it's also important to allow for flexible adaptations to enhance fit and promote equal access to EVPs. So that's all I have about the journal article. These are some questions that I developed for, to facilitate discussion. So we can go over those if you want, or if we just want to start an open conversation, that's fine too. It's up to all of you.
Heidi, very nicely done. I wonder if just to start, let's let people take a look at this for a few seconds, and then I'll have you pull them down, and that'll let you see the chat in real time too. Which there's a lot of great questions and comments in the chat. I will help us kick off what we're doing with the chat by Mustafa had a nice point that I'll let him verbally say that relates to adaptation due to workflows, whether those are clinical or other workflows, as compared to adaptations due to patient factors. Mustafa, do you want to add anything to elaborate to that question? And Heidi, I'll let you think about it while we have him verbalize.
So this paper heavily talks about like the adaptations to accommodate more patients or more diverse patients with more diverse characteristics. But how about adaptations due to clinical workflow, like due to what clinicians used to do and some clinician related factors, so that they don't talk about it. And also from the informatics literature, we know that we study clinicians' workflow to make sure informatics
intervention
is a fit to the clinical workflow.
And Heidi, you may or may not want to pull your slides back up and go to the one that had the different adaptations, because it might just be even fodder for us to think about that. If any of those things related to part of the, sometimes I think we could think of that as also the protocol that the research staff were following. It could be a piece of a workflow. That's just a possibility. But Heidi, what are your thoughts?
Oh man, I know, Mustafa, that was a lot. I'm trying to remember everything that you were talking about. But yeah, in this specific study, they didn't really talk about like clinician workflow at all and tracking those adaptations. And I guess this is something that like, where this is probably not going to address your question at all, really, but this is something that like we're talking about in our programs, that I'm working on with Kathy, is like, what adaptations are important for us to track, and like, how do we want to, what aspects of the workflow are important to do, and what are we going to report on, and so I don't know, maybe for this study, like maybe they didn't care about workflow for the clinicians, and so they didn't, request those providers to track that, but I'm not sure.
That's a great comment. One of the things that stood out to me was something like, if we think of it as a policy, right? Like the gym said, we're worried about these patients acting up in here. There were some things that were a challenge for how they thought their workflow would go. That's just something that struck me.
Right. Can you guys see the adaptations thing? I pulled it back up.
Yep.
Okay.
And maybe this is a good time to go to Rebecca's question, which is also perfect with our guest here, thinking about form and function, and it's garnering a lot of comments in the chat too. Rebecca, do you want to state your point?
Yeah, and I promise I didn't tee this up specifically for Monica, but I think it's just really relevant to this question of form versus function and identifying core components. And, is it a core component? I think Tina put it really more succinctly in the chat, if it can be adapted and actually improve the benefits of the intervention. And also just kind of thinking about, how are core components really identified? And to me, when I read this, I don't know enough about the intervention, within the context of a few short pages, but, it didn't really read to me as an adaptation that was fidelity inconsistent. And I think if you looked at this through a form and function lens, would you come to a different conclusion? And so I'm, just kind of throwing a lot of things out there, but I'd be curious to hear what others think about that.
Yeah, I thought that was an interesting. Sorry, does someone else want to go?
I was just going to add that I like Rebecca's point. So it gets a little bit confusing when I see this table, because the boundaries between what's a core component and what we can change become so blurry and confusing, in my view. For example, cultural adaptations tend to focus on translating and providing a language of preference, which are very concrete activities. But as Tina mentioned, we can think in terms of these two concepts. What is the in-shape goals that we must achieve? I don't think that by changing the location, we are impacting the fidelity. To me, the location where we do it could be seen kind of as an activity that's helping us achieve a goal. What is the goal of the meetings at the location? I didn't have a chance to read the article, but what will be the concrete goal, the function of in-shape with these interactions? Whether at the community, whether at a church, whether at a gym, that should be kind of tailored to each community. It might work at a gym for another community. It might work at a church, conference center for another. So I agree. I think it's just, if we think of components as activities, processes, core goals, and everything goes, it becomes quite a little bit challenging to identify boundaries. And I think Mustafa or Amurav, or both mentioned it. What's a workflow? What is and the relevance of quality improvement? So I just wanted to mention that to me, by just identifying the boundaries between what are the core functions, what is it that we want to achieve, all of us within SHAPE, and then allowing each community to do the way that work for them in terms, again, location, who is doing it, and foreseeing the challenges at multiple levels. I think someone else mentioned it, yeah, what would be the impact on the workflow for clinic personnel? And it is obvious that they didn't feel they were qualified, and there were some concerns for liability issues.
Excellent comments, Monica. Heidi, do you have any of the other comments in the chat or questions that you wanted to pivot to next, or any elaboration on this you'd like to elicit?
Can I stop sharing my screen so I can look at them?
Yes, absolutely, absolutely. While you do that, because I know it is really hard to look at the chat while you're sharing the screen, I'll just point out one more person to speak, and then Heidi, you can direct us how you'd like to go next from what you're seeing, or if there's a question you'd like to pose back to the group from those you had. But Claudia, I really liked your point about who decides. Do you want to amplify that a moment?
Yeah, I think that, thanks, Amy. I think that it goes around what everybody's saying, is that who decides what the core components or the adaptome that we talk so many times are, and what is that can be changed, and who decides that something is not really aligning with the fidelity. And I think that it goes with what you guys have been saying. I think that it's a very fine line on what is the cultural adaptation or the adaptation to context. And I'm not sure that this paper, I thought that it was a little bit rigid in their definitions of not being fidelity consistent. But because in the process of QI, you might be changing things in order to make it fit to context and to social determinants of health, and to real life situations. And that's what we all do.
Excellent points. I kind of reading between the lines on what you were saying there, and what I thought you might have said was, you know, if there were multi-stakeholder, if we convened the stakeholders, maybe that PRISM would encourage us to consider, or others broadly, and had them come to consensus on a core function and potential forms, it probably would have been different than what the researchers had decided would be the function, is my view.
Yeah, and that was the other point. Who made that decision on what was determined the core component, and what determined the fidelity? Who made that fidelity check?
Yeah, who should be the one to decide, and who did decide? Good points. Good points. Heidi, where would you like us to go? Would like to give you purview, and would also like Russ to let us know in the chat. I'm guessing we get another 5 to 10 minutes, but he'll tell us in the chat for sure. But Heidi, where would you like to direct this?
Well, something that I guess I'm interested in. So, and even like looking at the discussions that people were posting in Canvas, like this whole idea of like the frame being kind of like tedious and difficult to use. I just want to understand better, like if people have used the frame and how they've used it, and if there are other things that people have used, like in terms of tracking adaptations.
You're asking us to be pragmatic and speak to what's worked for us. Is that the question, Heidi? You want to hear, are people finding ways to make frame work for them? Or are there other things people have found useful?
Exactly.
Great question.
I'll just jump in. It's Russ. I'll just jump in briefly, and then others, particularly the VA colleagues, but including Heidi, might want to comment, because Borsika has led us on applying a number of different, I'd say, adaptations of the original frame, the adapted frame, frame IS, and trying to integrate those. I think our experience, I would say fairly consistently, would be that it is maybe overly complex, that some of the distinctions are difficult or challenging to make. And in my opinion, some of them, like what is adapted, I think has 12 different things. And often like 9 of those are checked in an adaptation. So I think it's challenging. That said, I do think it's helpful to have those issues in your head about kind of what are these key dimensions going along. But I think again, maybe the play on words, having maybe an adaptation of the adaptation framework to fit your particular setting. We did that. Our first use of it was a long time ago with Jody, and I'm looking to see, she's going to join us later today, I think. But we did it with patient-centered medical homes. And we found that was the very first frame that we'd had to adapt it a little bit to study that to make sure we got all the richness there. But I would love to hear from others. And again, since Jody's not on, I know maybe I'm forgetting some too, but I know the VA colleagues have done a fair amount with it or an adaptation. So I'd love to hear your input.
Heidi from the VA was asking us, but I don't know, Kathy, can I pick on you?
Sure. And I'm going to pick on Heather too, because we've both had slightly different projects and approached adaptations a little differently. But I do think that at least in our situation, the end users did identify what they thought were adaptations from the way we presented the core functions of our intervention to them. So they had their own opinion about what they thought was an adaptation. And I think definitely the research team had an opinion about what we would consider an adaptation and what if we would, I don't know, accept might be too strong of a word, but whether or not we, kept an adaptation to one of those core functions. I think there was a lot of discussion on that, but, it didn't seem like there were a lot of really hard rules about calling something an adaptation or not. And it really took a lot of discussion between end users and our team. And we did a lot of retrospective analysis of some of the changes we made. And I think that's where we're trying to change it in our new funding and our new project, is to really kind of be a lot more proactive in identifying an adaptation. But Heather, what do you think about it, from TMP kind of idea?
Yeah, I mean, I'll piggyback off of that. So we worked with Borsika early on, and this is now, 7 years ago, to track adaptations within our care coordination program. And we did it academically. It was very rigorous. We had a tracking sheet. It actually has all just been recently published, but it didn't help us actually do any of the implementation, right? It was an academic exercise. And at the end of the program, when we looked back on it, we thought, wow, we should have acted on those in real time, but we were drowning in other things. And so I think the future of it is real-time tracking and real-time determining if that adaptation is crucial to implementation and sustainability. And that's a big ask. We're trying to do that in Kathy's program right now. And that's a big lift, and it takes a lot of resources. So, another new field that we need to expand into.
Thanks, Heather. And I thought I saw Monica starting to talk. Monica, did you want to chime in there?
Yes, I wanted to share about flexibility. We talk about adaptations and deviations. That's another layer. What's an adaptation? What's a deviation? Retrospectively, prospectively. But I think we can do both in terms of planning as much as we can, but we think of context as being dynamic and a lot of things changing, especially in diverse and or under-resourced settings. To go to Heather's point, I completely agree. We are barely meeting the essentials for a project, for a grant, for a pilot, and then we are tracking changes, and that's a lot of work. But that's why we need the methodology to align with the needs of be flexible, the needs of the context, and the need for us to catch changes as we go, because we know context can modify our strategy as an intervention, for example, during implementation and after. So we really need to modify funding options so to allow us more flexibility. And we need to catch those changes. And I love Heather's point, make changes live, or at least catch them and be able to react. Just to give an example, and it's not perfect, but for a project we're doing where we are having different clinics be part of an implementation strategy, but they're taking turns, a stepwise design. So we allow one clinic to start and we learn from the process, and it leaves us a little bit of room for them learn, catch any changes that are needed, adaptations, and then move to the next clinic. And it's still a strong design, for example, that without undermining validity and the integrity of the design. So that's my point. I don't think we should try to control what it cannot always be controlled, and it shouldn't be controlled. And if we are more open to allow changes to happen, we need to be able to catch them and act on them. But then that means we really need to align methodology and even funding sources. So there's just a lot of work still need to be done, in my view.
Thanks, everyone. And I was just going back to, the presentation that Shannon Wilty-Sturman did for us at CopperCon on using Frame and Maddie to guide and track adaptations. I'd point people who want to kind of refresh on this material to consider going back to that. She did try to remind us of some possible ways to do things more prospectively, but I think Heather's comment about drowning in the information and the extent to which you've got like this really detailed tracking forms that don't let you really flag nicely what to do. Anna Bauman's team that developed the idea, approach to have kind of a idea being iterative decision-making for evaluation of adaptations that they published. I'll put it in the chat, the link real quick, but there are some things out there. They're just not easy. And Marie, I'll try to put in the link to that presentation in the chat, as well as that article that I was just mentioning. But I go back to that presentation regularly to try to, this is a tough nut to crack, I think, for all of us. Let's see, we've got a few more minutes. Heidi, did we accomplish anything that you were hoping for there with that dialogue?
Yeah, I mean, I definitely think so. I think that tracking adaptations is always, it's always a challenge. And even I think back to like when I first started in research, and I was like the social worker implementing this intervention, I was even like, I don't even know what an adaptation is, and I don't even know how to track this. So what are you guys talking about? And so I don't even know if I did it right. And so I guess a question that I have for you, all of you, in the next, 2 minutes or whatever, how do you make sure that your providers are actually tracking adaptations and reporting ones that are happening? Because I feel like a lot of times, we might miss them.
I have no answer except that I'm sure we miss them a lot, Heidi, because people are doing what works and they're not necessarily thinking of that as an adaptation, especially if you're not in an academic setting where you have trained up somebody to some criteria to be amazingly like high level of fidelity to whatever your protocol is. If you're in real world settings, people make things work all the time. So I think unless you go back and in extreme detail, as close to the time when they're actually doing it as possible, in excruciating detail, go over what this is, I think it's pretty hard sometimes to get people to accurately describe to you what they changed, because they don't even realize they changed it.
Yeah, exactly. And that's, I guess, I don't know, that's something that I'm worried about with the programs that we're implementing at this point, because they're so large and so many staff. And so I think that we might just end up missing things and not be able to carry over appropriate adaptations to more sites as we implement, because we're doing like the stepwise design. So as we like implement at more sites, how can we carry over the adaptations to make sure that it's successful and that we don't run into similar barriers?
Well, and are the contexts the same to carry those? Like, I think sometimes we might not want to. We might want to allow our clinics to figure out where their adaptation needs to be, like, sharing what's been done, but it might not apply somewhere else.
Right, exactly. That's such a good point.
I also wanted to add that perhaps if we don't report some of these adaptations, maybe looking at unintended consequences, and we're missing that relevant information.
Russ put something about the frame IS in the chat, and I really I appreciate systematic approaches to everything. So I like the frame, but that slide is insane, Heidi. When you pull it up, you're like, oh my God, how are we gonna do all of that? But like, what resources does it take to do that? And at least the frame IS is a little bit simpler. And I feel like, it's possible. I feel like tracking in real time is very helpful because of the recall bias, and knowing what it is that you're trying to track is helpful, and having a systematic way of doing it is helpful, and that we just need to keep working on finding the best way to do that. And I think taking a step back to like what Monica said earlier about how flexible is the thing that you're implementing in the first place. Like, what you're really kind of trying to track is maybe how people flex, like less whether they're adapting a core component that is like holy and can't be touched. They're sort of different ways of looking at it.
That's great, Tina. So I'm suggesting we call that our last word, so to speak, on the subject. And let's all applaud Heidi for an excellent presentation. Thank you so much, Heidi. Yay.
Yeah. Thanks for your participation, everyone.
Over to you, Russ.
Well done. That was a great discussion. So now we really have just some open-ended time for a fun discussion. Just to frame it a little bit, Monica has graciously agreed to be with us, and part of it is just for her to get to know us a little bit and how we interact with each other and things. But without putting you too much on the spot, Monica, I just wonder if you have any either observations from the time you've seen from us so far, or any like key questions you might have from what you've heard, like about where we're going. And then I'm sure a number of people, and I'd like to especially give a chance to people that have not had a chance to meet Monica to jump in. I think we can try and do it verbally. We have a lot of people, so feel free to also use chat, but it'll be fun if we can actually have an actual conversation, I think. But Monica, we'll just let you see if you want to start out, if you just have any reflections or questions for us.
Thank you, yeah, for giving me the floor, Russ. I really like the conversation and the activity on the chat. Both, I think we need both. I still think it is such a relevant area, adaptations and where we adapt, and we have made so many advances with frameworks, but I think we still need to discuss issues of our paradigm, theories, what is guiding, what is the roadmap, what is guiding, what are the boundaries, what is our philosophy in terms of changes, and how do we see communities and context. I think that will be helpful in terms of getting us in the same place. And as I mentioned, as a roadmap, how do we think about changes? What is a cultural type of adaptation? Is it just changing the language? Does it mean, in terms of health equity, does it mean, I have a problem when we say we are culturally tailoring an intervention. What is exactly that? Could we think of cultural changes in terms of adding functions or no? So I think those discussions more upstream will also be very helpful.
Great, thank you. Thank you. So are there any questions? Maybe they don't have to be for Monica, but I'm just trying to think what might be helpful for her to know about, how she might potentially fit in with our group, or maybe some directions that, especially those of you that haven't met with Monica yet, are thinking of going, that would be good for her to hear about.
Yeah, I can jump in, Russ. I will say, like, the form versus function, I find that really helpful in terms of thinking about intervention development, which is what I'm working on. And I really like the idea of like having your function really well defined and then like lots of different forms that it could take place in. So then when someone does go to adapt it, there's already material ready to go for any different context or setting. And I just find that idea really intriguing. I haven't applied it yet to my work, but I find it really helpful in the way that I think about the intervention that I'm developing.
Thank you, Danielle. And for the work that we did with functions and forms for patients in a medical home, we actually developed a menu of forms that we pull from the literature. But then as we apply this concept in one of the biggest FQAC system in Southern California, we added and we compare and contrasted. It wouldn't be wonderful or very helpful to have when we are developing, like Daniel mentioned, or evaluating an intervention or a strategy, to have that menu in a database or in a centralized place that has been tested and with information on, okay, we know that these type of activities or processes or steps are really helpful in rural areas with yes, in community-based clinics. I'm thinking of something. So we have a starting point. It's just when we have to, it feels a little bit like we have to start from scratch and trying to figure it out and really rely on our communities to discuss issues. But I think we really need to centralize what works, where, and with whom, not as a recipe. It will not be a recipe because then we are kind of denying the dynamic nature of our communities and that our communities evolve. That's what we mentioned in the paper, that the activities should evolve because the context is changing. So if it should evolve, wouldn't we then expect always to have adaptations? And then why would we be concerned about fidelity if it's an expectation from the system and the context itself? So we really need to think this through more flexible and connecting the dots within and across.
Good. Anybody want to follow up on that line?
I can just verbalize what I put in the chat while others are chewing. I love, these thoughts, Monica, and it was making me think about the adaptome paper, and the notion that we would empirically have empirical data on different functions and different types of context. And like you were saying, like if this seems to work well in rural settings, maybe even getting more discrete than that, like rural settings that do have this type of community resource or this type of social determinant of health resource, or you were bringing in the cultural context as well, if there's certain subpopulations. And it feels like when I think about those things, that we just need a much more of a rich informatics source and ways to categorize these different types of context richly, and then, as you said, could better understand. What I like to always say is kind of like the Yelp for researchers and settings, like what works in settings like us for interventions like this with functions of this sort. So I'm just reflecting aloud, but everything you were saying is what I think we'd like to get from that being an aspirational goal to being closer to reality.
I just want to build on that a little bit, or come back to one thing to let Monica know if this hasn't come up in other conversations, but pick up on the point about the rapidly changing dynamic context, that we're all, how could you not have that hit you between the eyeballs over the last couple of years? But a number of us are interested, really in context, not only understanding it, but thinking how can we better help our partners, our communities, our clinical partners and things, to align with context, and maybe even to try and get ahead of the game a little bit to think about what's future context likely to be. And again, many, but not all of us are using our PRISM framework to think about that. And some of you might know a little bit about work, again, that Borsika is really leading, but Katie's been a real key partner in that too. And so Katie, if I could put you on the spot a little bit, I don't think a lot of the people know about the work that we're doing with the PRISM interactive tool. And I wonder if you'd mind just sharing a little bit about that.
Sure. I'm not sure exactly which direction you want me to take, but high level summary of the work that we're doing. So similar to, well, not as impressive as the work that has been done with the REAIM website, we are now working to create a website that makes the PRISM, applying PRISM more accessible, more approachable to different types of audience. It does link out to REAIM and includes REAIM within that because PRISM includes REAIM. It's still under development. We're going through lots of iterations of all sorts of user-centered design. Russ, my guess is you wanted me to take it in a different direction, but I'm not sure which.
No, I think that's just it. But this notion, well, maybe just a little bit, and I'll embarrass myself and show how my forgetfulness. But after we assess very briefly a series of 2 or 3 questions about each PRISM dimension, and then we'll know about the REAIM outcome. That's important to them. Then we provide some immediate real-time graphical feedback and things, well as text about the dimensions there. And then this leads into a type of fairly open-ended action planning or whatever, when they think about each of which dimensions seem to be most important and most aligned. Is that right, Katie, or did I get the dimensions wrong, that we have them rate the domains on?
No, I would say that's correct. We actually have them rate both, well, let me see, PRISM dimensions, right? And REAIM domains, or did I flip that? They do both.
Yeah. Well, anyway, enough about that. I just wanted to tell you that's one direction, I think, one specific way that we're trying to do this, to think about context, but there's a whole lot going on. And in the spirit of, sharing and giving other people a chance, how about if there's anybody else that's working on something about understanding or helping guide adaptations to context, please you jump in, and then we'll see after that if Monica either maybe doing things we're not aware of or just has any reflections on that direction.
One thing I might add, we haven't gotten too far with it, but the Center for Personalized Medicine that I work with, the Piccolo Group, Pharmacogenomics Implementation, Colorado, we have implemented a number of CDS and EHR for clinically actionable drug gene pairs. And we realize that over time, adaptations will be necessary for a variety of reasons. So we've taken the frame in general, and we've tried to make it more practical and feasible and relevant to the CDS context. But as Claudia pointed out, it's kind of overwhelming to start off with, and we adapted the adaptation framework. We haven't actually used it yet, but we put it into REDCap and looking forward to using it.
Anybody else?
I love to test it. So count me in.
Great. And again, as Katie put in the chat, several of you have already helped us with some user testing on the PRISM web tool. It's an ongoing effort, and we'll be testing it. The eventual goal is to have it be something that can be used together by probably an implementation science, or at least a practice facilitator with teams, clinical and community teams in partnership. So not just a research tool, not probably expecting it, at least now, for community groups to be able to take off and totally use it on their own, but in a way in partnership that you can use that together. So anything else on context that people would like to add about directions, or it could just be thoughts, even if you're not doing anything actively now, key needs that you see?
I can chime in briefly. We were inspired for our project, the school-based asthma project that we're trying to disseminate across Colorado. We were inspired by an approach that Ocean did for implementing their social determinants of health screening with FQHCs. And Monica, they took their functions and through stakeholder engagement, they worked on developing a menu of forms for those functions. And then because they knew they had limited bandwidth when they would actually work with the clinics to do their planning, they created what they affectionately called a Mad Libs form. It was really an Excel sheet that just had a menu, a drop-down menu with those different forms for the practice to choose between the forms. And it was their effort to simplify the process of choosing amongst forms for each of the sites to be able to put it all into one Excel sheet with different drop-down menus for those. So we adapted that for our project to try to do something similar. But I just wonder if you had any other comments you might share with us on ways that you found it helpful. I know you had a spreadsheet you were talking about for like forms and functions that even a stakeholder emailed you about how they were planning to use it in their next set of work. So obviously it was accessible to them. If you want to make any comments about making these things accessible.
Yes, I am such a lover of Excel tables because it works so well with our community partners and it makes it so much simple, doesn't require specific skills to manage. So I tend to use, yes, Excel tables to translate these concepts of what I'm doing in RedCap or other systems. I love, Amy, your feedback, always giving me even ideas in terms of drop-down menu of forms in fast-paced type of research, because we talk about that we don't have a lot of time, and it doesn't need to become a recipe, a restraining tool, but it gives us some starting point. So yes, so I was going to mention two points. One, yes, I also use the matrix that we developed with 3 simple columns. Is what are the guiding guidelines or the principles or the areas that you want to focus on? What are the problems that you're trying to address? What are the 2, 3, or 4 main goals that you need to make sure they're being achieved? And then the menu. And you can create a database where you can ask, as I mentioned, Amy mentioned it, we can do ethnographic methods, really embed ourselves in the context. Or document review, and start populating that simple 3 or 4 column table with our partners. I would like to, I'm doing a little bit of intersecting that matrix with implementation mapping. I like implementation mapping because it can be very cumbersome, but I've been using what I think is simple is the what, who, when, and why, especially the why. It has helped us address what someone mentioned, who is making the decisions. So I think it should be in collaboration with our community members. So trying to intersect and making it simple. I usually put in an Excel table, our call goal, this is where we want to go, and it's really big, and I share my screen because now everything is Zoom, and that's the core function. And then I put it in a columns. What is it that we need to do with challenges? And I start typing so everyone can see how things are emerging. So I type as we make decisions and as we talk. And it has been incredibly helpful. Our partners can see the process emerging, what we change, what we do, and a matrix kind of emerges at the end of our planning group or our stakeholder meeting. And we did it all together.
That's great. Thank you all. Let's switch a little bit here, given the time, and just see if there are any other directions. Obviously, there's an incredible amount of interest and synergy here, and I think a lot of us are either very interested or have had some positive experience using some type of form function, either the matrix per se or other ones. But I'm just wondering if there are other things that people would like to either ask Monica about in terms of work she's doing now, future directions, or just anything you might be doing, see if she has reflections on that. It's really just open-ended time to have a free-floating discussion.
And while you think of that, I would love your thoughts on the role of quality improvement and quality departments in your work. Because what we do, especially with implementation, comes so close to quality improvement and issues of sustainability. So I would love to hear your work and your thoughts. Do you think these adaptations should be housed at some point or our research in a quality improvement department with our members, or it should be different? So any thoughts that you have on QI, I will be very interested.
Yeah, anybody should feel free to do it, but I'm just trying to risk of putting her online because Amy Tyler is kind of one of our people that lives closest to QI anyway. And if Amy, I think she's still on, but she might or might not be available now, but maybe she could start out with that response anyway, if you're available, Amy T. I have a phone. I don't know if any of you can see that. Why don't others jump in here? Maybe she's having some connection problems. I see her on the phone and then I see her phone going on and off, the mute going on and off, but we'll see. Why don't others jump in on that issue about the interface and particularly here, on campus, interdigitation with QI or not. Again, I certainly don't want to put words in anybody's mouth, but the VA lives, a lot of that on that interface. So some of you, I think, Monica, we have a really, I think, strong relationship with our VA and our query program here in particular, as well as GREC. I guess Dan isn't on today, but not sure if you know about the GREC geriatric centers or not, but we have one of those too.
From the UC Health perspective, I'll just share that we have a really robust QI team, both of faculty as well as staff, and they're very focused on training, which is pretty exciting. So every year they offer, they call it the IHQSE, Institute for Healthcare Quality, Safety, and Efficiency. And I'll put the link in the chat. And I went through it a while ago. I think it's a 1 or 2 year program where clinical teams go through formal training and apply it to operational care gaps in their particular setting. But it's really robust training. Also, yeah, I'll just stop there, but we have a great UC Health representation.
Great. I see Amy T is trying to weigh in here too. We've got some audio difficulties. Let us see if you can. If not, maybe if it translates into text, you could put it in the chat, Amy. Got it. Mic not working. Okay.
I was gonna jump in with my recent experiences. Hi, Monica. I'm Anna Ma. I'm a adult hospitalist at the University Hospital. I'm actually a newly graduated K-12 scholar. And my work involves implementation of a new technology, point of care lung ultrasound. But I'm finding a lot of synergy between my quality colleagues. So hospital medicine is sort of, especially known for its quality improvement involvement, and finding a lot of synergy between my, quality expert colleagues and the work that I am doing. And one is, I think that the quality folks are very interested in finding more support in terms of grant funding for the work they're doing. So I think there's a lot of synergy there to do these quality pilots that can be then developed into sort of bigger studies that you're trying to replicate results of a successful quality improvement study in your one hospital and then try to replicate it in other places. So that I've had a really positive experience with that intersection so far.
Did that, I wish you'd all jump in here. Otherwise, you know me, I'll just start talking or go some crazy direction or way. But I'm just wondering, following up on that, thinking about the optional paper that we put out today, Monica, that you sent us, that had a lot of folks, including some of the ones here on embedded research. And I'm just wondering about reflections for that, because that I think is a lot of many settings is partnering, with the QI folks and that sort of thing in terms of doing embedded research. And just wondering if you wanted to reflect, Monica, on any key points from your perspective about that, about successful embedded research, or even reflecting on that conference or directions for the future in that area.
Yeah, sure. So this paper came as a result of an embedded research conference that Brian Midman and others put together in Pasadena. Two key points that I really like that came from that work and what we published. The first one is to think, could we think of research and QI as a continuum, where we can get closer, as Anna mentioned, I think it was Anna, and working with our QI partners to really benefit, so they can benefit from our expertise in really defining clear research questions. QI folks are so good at improving what they're doing, and really doing training, but could they benefit from us supporting them with research questions, supporting them with extra additional funding, usually to do something more in terms of like a randomized controlled trial, for example, something with more rigor. So that's one key point. Could we think of research and QI as a continuum? And if so, I included in that paper a toolkit that we discussed. And I mentioned it during the conference, and I included it in the table. It was a key point that implementation science there can help us get there. I see it kind of as a bridge. Implementation science can help us as researchers provide to quality improvement folks of the department information on how to embed what they're doing with their context, with their environment, and how to test it, and what specific strategies are being used to really learn from their own data. At the end of the day, that's what they want to do. They want to do better at learning, catching, gathering, and documenting and analyzing their own data, and creating fast cycles of feedback to create change. So those were a couple of points that came out of on that conference. And also in terms of expanding our toolkit, and you can see there in a table where we are arguing that we need that flexibility that we discussed in methods to align it to the research questions that we're posing. Theory, discuss theory of innovation in terms of differential advantage of what we're doing versus what we're proposing to do. But in any case, I think it's important to also think of the role of implementation science and embedded research and in promoting learning systems. What would that mean, and what do we need? Which partnerships, internal partnerships do we need? And I think quality improvement experts and departments are a key player that sometimes we don't include at the table. That we still see it as separate processes, but especially for process evaluation, which is a key part of implementation, we need them and they need us.
Excuse me, I put myself on mute. Anybody have a follow-up thought on the embedded research? Or I know Jody's here now, and I know she was at this conference, and I forget who else was. I think somebody else too. Amy?
Amy Hipschman and I went. Where's Amy?
I'm here. We were roomies.
Yep.
That was fun.
Yes, we were, and I locked her out of the room. Do you remember that?
I forgot that.
This, excuse me, this may be TMI, but
I'm just letting you know we have fun in a good way.
That's
So anyway,
amazing.
yes, no, we went to that conference. What was your question, Russ?
I just wondered if you had any reflections, either on the meeting, what Monica just shared from it, or if you had any reflections, either the meeting or just kind of your own thinking or our kind of approaches to embedded research.
Well, I can picture being there at the meeting, and I'm trying to remember all the, without any, it was at least 2 years ago, 3, 4, I mean, it was a little while ago. So I remember thinking, walking away from that meeting, that embedded research worked really well when there was the structure and the culture and the place to do it. Like a lot of the people there were VA and Kaiser and these really big organizations. And I remember thinking, since I do so much in primary care, I was like, well, how does this work when you don't have this great big, health system, when you have primary care practices out there on their own, kind of working, doing things. And so I'm very much in favor of it, but I think that the way that it actually works needs to be broadened and included in other environments, not just in the VA and Kaiser and places like that. So that's what I remember kind of my walking away wishing was a little different, but I think there's a lot to learn.
Completely agree, Jody. There were big systems, many were private. Right. We did not have enough or at all, I think Amy corrected me, patient representation. We had, I think, one patient.
Yeah, there weren't any patients there.
So I completely agree. We still need to think about many of you are doing research within your own systems. That's embedded research. We need to keep developing this idea of what's a learning system and what's embedded research and when and how and why, and how to bring smaller systems, maybe underserved public safety net systems into the agenda if in fact that's a way to go. I completely agree with your point, Jody.
Thanks. We don't have time today, but I just will tell you one of the areas that we're trying to do work on. Several of us are doing different things, doing health systems, but to try and learn a little more and coalesce or integrate that, we're doing each year we do a webinar series through our CORDS education program. And the theme of that is learning health systems this year. And Bethany Kwan, who couldn't be here today, and Katie and Amy are all key parts of that. But we're trying to look at different models and things, including some that, might be broader beyond like the clinical setting to engage the community more and that sort of thing too. But we see the clock is ticking here. So let me turn it just a little bit and see, Monica, if there's any question you have for this group now.
I appreciate the invitation, and the group is very diverse and bring different questions and voices. Question for the group. I was just wondering how you set the topics. Do you set a different topic every time you meet, and how do you kind of link the discussions from one topic to another? I'm curious how this flows. What's the dynamic?
It's magic. It's a system we've been working on for decades to come, but it's proprietary, so I'm afraid you can't share it. No, maybe Amy, you want to talk out currently, and Amy can explain a little bit. This meeting has multiple purposes, how we do this, but I will say the one thing we try to do when possible is have like one article that's kind of a journal club about a topic, and then where we can then like a work in progress or a more applied thing, on a related topic anyway. But Amy, do you want to say a little bit more?
Sure. Well, engaging our stakeholders. So one of the purposes for this class is it's a course in our D&I certificate. So many of the students who said they were part of the certificate are taking this for credit, for graduate credit. And so we do let them pick the article they're going to do for their journal club from a menu of articles. And we do try to balance. We've had some discussions as a team about how to be strategic there. And we've said we want to prioritize articles on D&I and equity. We want to prioritize articles on certain areas of emerging D&I methods. Adaptation was one of the areas we've looked at, how we tailor implementation strategies to context. So as we've identified those strategy areas, then we try to have people send us articles. Hey, this was just published. This would be great. And we try to vet them and put them on a list. And then our students do get to pick the actual one they'll present. So that way they aren't just assigned something and they're like, what? I don't know anything about that.
Thank you, Amy.
We're very stakeholder engaged.
I wanted to mention that I'm really sorry. I'm going to have to leave a few minutes early to get to another meeting. But I wanted to thank Ross for inviting me and everyone for the warm welcoming and for including me in this conversation. I truly enjoy and I learn from this conversation. Thank you.
Thank you for coming.
Absolutely. And it's good for us
Ross-
to end a couple minutes early just so we're not all zombies anyways, maybe.